This lecture is regarding the basics of ECG interpretation, the tips and the tricks. We all know regarding the conduction system of the heart, which begins from the SA node, goes on to the AV node, the bundle of His, the right and the left bundle branch. The left bundle branch further divides into the left anterior and the left posterior division, which further divide into the Purkinje fibers. Not just the cells of the conduction system of the heart, in fact, each myocardial cell has an intrinsic atomicity. But because SA node fires at a very rapid rate, SA node remains as the dominant pacemaker of the heart. The cardiac cycle and the ECG go hand in hand. The P wave represents your atrial depolarization. The PR interval represents the intrinsic AV nodal delay. This intrinsic AV nodal delay is important to ensure complete emptying of the atria into the ventricles and to ensure that the ventricles are completely filled before they begin to contract. The QRS complex represents your ventricular depolarization and the T wave represents the ventricular repolarization. The 12 leads act as the 12 cameras. The 6 limb leads view the heart in the sagittal plane and the 6 chest leads view the heart in the coronal plane. So in effect, we get a 360-degree view of the heart. And in fact, each lead represents specific regions of the heart. Lead 1 and AVL represent the lateral region of the heart. Lead 2, 3 and AVF represent the inferior region of the heart. V1 and V2 represent the septum of the heart. V3 and V4 the anterior wall. And V5 and V6 the lateral wall. You can see the 12 cameras in action now. The heart has numerous vectors and the electrical axis is actually the summation of all the vectors. The electrical axis is between 0 to 90 degrees. So when the wave of depolarization occurs in this direction and if the measuring electrode is placed here, so if the wave of depolarization moves on towards the measuring electrode, it is recorded as a positive deflection in the ECG. And if the wave of depolarization moves away from the measuring electrode, it is recorded as a negative deflection in the ECG. And if the wave of depolarization is along the measuring electrodes, it is recorded as a biphasic form in the ECG. So hence we have different morphology of this QRS complex and other waves in the ECG. Because the QRS complex is away from the measuring AVR electrode, all the waves in AVR are negative. There's only one condition where the waves will be positive in AVR, that is dextrocardia. So all the negative waves in the AVR ensures the correct placement of the ECG leads also. So always remember there's only one condition wherein the waves will be positive in AVR and that is dextrocardia. We can also see the gradual progression of the R wave that occurs from V1 to V6. Before knowing to interpret the ECG, we should know to interpret the ECG paper also. So each small square represents a duration of 0.04 seconds and each large square represents a duration of 0.2 seconds. And the sweep speed of an ECG paper is around 25 millimeters per second. And we should also look for the standardization of the amplitude. So usually the 10 millimeters represent 1 millivolt of amplitude. So we should always look for this sweep speed and the amplitude standardization before interpreting the ECG. It is easier to interpret the ECG if we divide into 7 steps or if we go in a regular way like rate, rhythm, P wave, the PR interval, QRS complex, ST and others. How do you determine the rate? The rate is actually determined by measuring the number of large boxes or the number of small boxes between 2 consecutive QRS complexes. So if there are 4 large boxes, then the rate is actually 300 divided by 4. If you are taking into account the number of small boxes, it's going to be 1500 divided by the number of small boxes. So if there are 4 large boxes, then the rate is going to be 300 divided by 4, that is 75 beats per minute. If you have 3 large boxes, then the rate is going to be 300 divided by 3, that is 100 beats per minute. The rhythm, the rate and the rhythm actually go hand in hand. While measuring the rhythm, we should always see if each P wave is being followed by the QRS complex and if the QRS complexes are occurring at regular intervals. If the QRS complexes are occurring at regular intervals and each P wave is followed by the QRS complex, then measuring the rate is going to be EC according to our previous formula, that is 300 divided by the number of large boxes. But what if the QRS complexes are occurring at varying intervals? In that case, we'll have to see the number of QRS complexes that are present over 6 seconds, that is over 30 large boxes, and we have to multiply that by 10 to get the mean heart rate. So in this case, we have 7 QRS complexes occurring over 6 seconds. So the rate is going to be 70 per minute. So now we are just going to concentrate on the rate and the rhythm in the following ECGs. So here we can see that each P wave is being followed by the QRS complex and the QRS is occurring at regular intervals. So there are 3.5 large boxes in between. So the rate is going to be 300 divided by 3.5, 85 per minute, and it is regular. So this is a normal ECG. Coming to this ECG, here also we can see each P wave is being followed by the QRS complex and the QRS complexes are occurring at regular intervals. So the rate is going to be 300 divided by 6 large boxes, which is 50 per minute, and it is a regular rhythm. So this is sinus bradycardia. So this ECG was recorded from a medical student during a practical class. So we can see here that each P wave is being followed by the QRS complex, but regarding the rhythm, we can see that the rhythm is irregular, but we can see some amount of regularity in this irregularity also. So here the QRS complexes are widely placed, here they are narrowly placed, and again they become widely placed. So this is an regularly irregular rhythm. So the rate is going to be 300 divided by 5 and 300 divided by 3. So the rate is going to be around 60 to 90 per minute. It's variable and the rhythm is irregular. If this irregularity is present in an asymptomatic individual and if this is associated with respiration, then we term this as sinus arrhythmia. The sinus arrhythmia is more common in males, especially young males who have a vagal predominance. This happens because the heart rate increases during inspiration and the heart rate decreases during expiration. So this is cyclical and so we have a regularly irregular rhythm. After seeing the rate and the rhythm, next we are going to check on the P waves. The best lead to check the P wave is lead 2. So whenever we are measuring P wave, we'll have to remember this 2.5 into 2.5. The P wave occupies a duration of 2.5 squares and it occupies an amplitude of 2.5 millimeter. The P wave is formed because of atrial depolarization. The first half of the P wave is formed because of the right atrial depolarization and the second half is produced because of the left atrial depolarization. So this is how the P wave is formed. So if there is any abnormality in the right atrium, if there is right atrial enlargement, what is going to happen? The amplitude of the P wave is going to increase. So the P wave is going to occupy more than 2.5 millimeters of amplitude. So we get a tall peaked P wave, also called as P pulmonale. This is indicative of right atrial enlargement. What if the left atrium is enlarged? Then the later half of the P wave is going to be affected. So the P wave is going to become bifid, wide and notched. So this is indicative of left atrial enlargement. So we get a notched or a wide P waves or a biphasic P wave in V1. So this is indicative of left atrial enlargement. This is also called as P mitral, which is commonly seen in patients with mitral stenosis. The other abnormalities that can occur with P wave are it can be inverted or polymorphic, or the P wave in turn can take the shape of a flutter wave, fibrillatory wave, or it can be completely absent. So this is ECG of a 75-year-old man who is a known COPD patient and has fever and increased sputum production. So now we are going to check on the rate and the rhythm. The rate, there is tachycardia. The rhythm, it is irregularly irregular. Now coming on to the P wave, what do we see? We see many different kinds of P wave. The P waves are morphologically different. So this is called as polymorphic atrial tachycardia. This is polymorphic because we can see many different forms of P waves. This occurs because there are many sites in the atria which take turns in generating the impulse. Hence, the P wave takes different shape. This occurs mainly in patients with lung disease. To term this as a multifocal atrial tachycardia or a polymorphic atrial tachycardia, we should be able to demonstrate at least 3 different types. You have to demonstrate at least 3 different types of P waves to term this as a multifocal atrial tachycardia or a polymorphic atrial tachycardia. And this is very common in patients with lung disease. Coming to this ECG, what we see here, we can see there is tachycardia. The QRS complexes are evenly spaced, but what about the P waves? We don't find any P waves here. The P waves are actually buried under this QRS complex and the T waves. So this cannot be termed as an atrial fibrillation because we don't find P wave, because the rhythm here is actually regular. This is supraventricular tachycardia. The P waves are actually buried under the later part of the QRS complex and the T waves. Here we have a 45-year-old patient who is complaining of shortness of breath and a racing heart.